K V S Harikumar. He is the renowned endocrinologist of the country and a very gentle and polite man, and is also managing our Endocrine Society of India very nicely. And on the first request only, he agreed to give this talk on the pulse in good cases for the cardiodiabetology. Puneet, can you mute it? GD, can you mute your mobile? GD, can you mute your mobile? So now, without wasting time, I invite Dr. K V S Harikumar to please start your talk on. Right.
Good afternoon, sir. Keswani sir, Parikh sir, and everybody, Dr. Minal ma'am, everybody. Thank you for this opportunity. I hope I am audible and my slides are visible, sir.
Yes, visible and audible both.
Perfect. So in the next 15 to 20 minutes, we will just see how we approach the patient with diabetes in relation to the managing the cardiovascular risk factors, which we all actually look for and take it for granted in the clinical practice, how best the guidelines are and how best to translate the guidelines and evidence into the patient who is sitting in front of us in the clinical practice. So these are all representative cases which we all encounter on day-to-day basis, but possibly which may be overlooked at some point of time, or maybe randomly we give prescribing some drugs, whether actually they are justification or not. So I shall discuss them on case basis. So the first case, 46-year-old male, 1 year duration of diabetes, and using metformin, sitagliptin, and atorvastatin. Total cholesterol of 185, A1C of 7.1, microalbumin of 18. A friend advised him to take a blood thinning agent that helps in prevention of stroke and IHD, because a lot of media awareness, a lot of issues. So this was the friend said, why are you not taking a blood thinner so that you can prevent the strokes? So actually, this is a form where we have more interactive session with the audience, but nevertheless, since it's an online one, I would just request everybody attendee to see a option in your mind. I will obviously discuss the answer later on, but you know how you are going to do. So if you have to choose this is the clinical profile of the patient, 46-year-old male, 1 year duration of diabetes, whether he requires a blood thinner or not. So what would be the next step? No change in therapy. Add an antiplatelet, add an anticoagulant, or add a newer anticoagulant. So
can any of us also answer?
Yes, sir, please.
Yes. So Dr. Minal, Dr. Ajay, Dr. Ajay's. So in my opinion, he doesn't need any change in therapy.
Perfect, sir. Perfect. So the important lesson, because most of the times we tend to randomly prescribe ecosprin the moment patient walks into the clinic. Sir has rightly said, you should not give anything. Aspirin as a primary prevention is to be given only in patients with increased cardiovascular risk. Not quantified this time, but generally in the atherosclerotic cardiovascular risk score more than 20%. That too discussing with the benefit and risk of bleeding with the patient. So blindly, please don't prescribe aspirins at the moment somebody walks into the clinic with diabetes. So it is not required. If he has risk factors, different issue. If he has secondary prophylaxis, we are not debating at all. This is for the primary prophylaxis. So sir has rightly said, please don't use aspirins routinely. Look at the indication and then start. So that is the first patient. We'll go to the second one. 42-year-old female. Duration of diabetes 3 years. BMI of 21. Using glimepiride 2 milligrams. Metformin 2 grams. Pioglitazone 30 and atorvas 20. A1C of 6.8 and microalbumin of 22. The family physician was surprised that patient is not using an ACE inhibitor and told her that it prevents kidney and heart disease. So why the patient is not on a small dose of ramipril, which was prescribed or is being prescribed by many practitioners. Maybe a 2.5 milligrams will give a lot of hope to the patient, taking cue from the HOPE trial. So what would be the idea at this juncture for this patient? No change in therapy, add ACE inhibitor or ARB in small dose, or maybe look at another RAS blocker, or add a CCB or diuretic. This is a profile of the patient. Any comments, sir?
As patient doesn't have any history of hypertension or any family history of CKD, so again we can wait for and do not start AC inhibitors. No change in therapy.
Perfect, sir. So no change in therapy is the correct option, most appropriate option. The issue of using ACE inhibitors and ARBs, they prevent the progression of microalbuminuria to macroalbumin and further end-stage kidney disease. But there is no prevention of microalbuminuria. There is no primary prophylaxis here. So that is important to know that these are the recommendations of using RAS blockade, ACE inhibitor or ARBs, not recommended for primary prevention. If you have anybody with a increase in the albumin creatinine or low GFR or evidence of kidney disease or hypertension, you are 100% safe in prescribing RAS blockade. So that is also important to know. So when to prescribe ecosprin, when to prescribe ACE inhibitor or ARB, very, very important in a given clinical setting. Don't prescribe randomly, regularly with the hope that they will prevent something. They may not prevent anything. We go to the next patient, third patient, 54-year-old female, duration of diabetes 6 months, no CAD in family. Current treatment, metformin 1000 milligrams and sitagliptin 100 milligrams. Fasting 100 and post meal of 136, A1C of 6.1. Total cholesterol 165, LDL 96. Physician prescribed her to take a statin Etervas of 40 milligrams. She is not convinced and came to you for second opinion. She has no CAD. Her LDL is 96 and glycemic control is reasonably good. So what would be the next step? You would support giving Etervas of 40 or maybe go down to a moderate dose of 20, continue with high dose, or maybe other hypolipidemics in the given setting.
So
this is the patient profile.
Yes. I think some dose of statins should be given as LDL is more than 70, which we wish to keep in patients of diabetes. I am not sure.
Actually, this is where the maximum what do you call the conflict with the guidelines and practice happens as far as the statin prescriptions. Definitely the prescription of statins, the recommendations are completely different, and possibly some difference is there in the usage of it. As far as primary prevention, 40 to 75 years without CV risk factors, you can just use moderate intensity. So you just require a downscaling of the therapy, not the full dose. If somebody has got multiple CVS risk factors, you should give high intensity therapy. In somebody who is young, who are type 2 diabetics, we are seeing like in 20s and 30s also. With the presence of CVS risk factors, you can initiate therapy depending on, after discussion, maybe a high intensity or moderate intensity, depending on the number of risk factors. And use of ezetimibe, if somebody is not able to bring down the LDL further down below after whatever the maximum tolerated statin. If you are looking at secondary prevention, most of the patients would require high intensity across the board. Only difference being higher age groups, because of tolerance issues, you may have to down titrate it. And if somebody is still LDL is more than 70 despite high dose statin, you can use ezetimibe or PCSK9 inhibitor. So Dr. Keswani has rightly said, you may require to down titrate, because here we are looking at the primary prevention and without any CVS risk factors. So a moderate intensity is good enough for the patient. We go to the next patient, 44-year-old male, had a recent acute coronary event, single vessel disease, PCI put in, history of diabetes in family members, A1C of 5.4. He was prescribed Atorvastatin of 80 milligrams because of recent ACS and a stent in situ. His Google knowledge revealed that Atorvastatin leads to diabetes, and he is not keen to take the statin and came for second opinion to you. So the issue of acute coronary syndrome has settled, but he is not happy with the dose of Atorvastatin because he said my family has a lot of diabetes, and I have read that this drug is going to cause diabetes. So what should we advise to the patient? Stop the statin, reduce the statin to low dose therapy, or use other hypolipidemics, or no change in therapy and advise lifestyle measures. This is a profile of the patient.
Yes. So we can reduce the dose of statins, I think. I am not sure. Maybe the third option will be the good. Patient
Third
is
option, no other hypolipidemics.
not recommended. So B should be the right.
Yeah, Dr. Hemant said D. No change in therapy.
Okay. Yes. So statins.
So
Yes.
the issue regarding the statin usage in diabetes, especially in somebody who has a IHD, there is completely different. It is, you should not change. The option correct is only D, because there is completely different as far as a secondary prophylaxis, secondary preventions are concerned. Only thing is, this is how you actually look at statins in diabetes. If you are in secondary prevention, high risk subgroups, you have to use Atorvastatin or Rosuvastatin because they are the most potent statins. So there is no question of reducing or maybe anything, because under to a recent ACS, he would be beneficial at least for a year of high dose of statin. If only you're looking at primary prevention of any cardiovascular events, and then possibly you may think of a low dose of the statin, or you can use Prava or Pitava, which are supposed to be less glycemic inducing rather than the other two. So if you are looking at reduction of LDL as a primary prevention in a patient who has no history of CAD, you can consider this Prava and Pitava. But otherwise, most of the other groups you would require using Atorvastatin or Rosuvastatin in that appropriate intensity of therapy. We go to the next patient. 50-year-old male, diabetes of 7 years, IHD of 2 years, already implanted, stent in situ, doing well, using metformin, pioglitazone, Atorvastatin, Ramipril and metoprolol and ecosprin. A1C of 6.7, fasting PP normal, microalbumin normal, and echo last done was normal. No issues of fatigue or effort intolerance or anything, clinically normal. But when his prescription was reviewed, a family physician was surprised that patient is using pioglitazone. He told him that it damages the heart and advised to stop immediately because a lot of issues regarding pioglitazone to the heart. So he said, why are you using? You already had a heart attack earlier. So what would be the next step? Stop the pioglitazone or reduce the dose of pioglitazone from 30 to maybe 15 or 7.5. Use other OHS instead of pioglitazone, or no change in therapy and reassure the patient.
Can reduce the dose of pioglitazone.
Okay, one option is to reduce. There are C and D option also has come. Yes. So B, C, D is the one which is as of now.
I feel.
Yeah, Dr. Ajay.
I feel that GLP-1, which is not OHA, but SGLT2 perhaps slightly better than pioglitazone.
Correct. I mean, we can even use in the current A1C spectrum with the history of IHD, where you can even use SGLT2 inhibitors, which are absolutely required. If no change in therapy, would it be option?
If the patient has got recurrent stent occlusions, perhaps pioglitazone is the next step, but that's only after SGLT. We run out of option of GLP-1 plus minus SGLT2. And we completely eliminate pioglitazone if there is slightest evidence of heart failure.
Perfect, perfect. So the most of the things have been addressed. Yes, the first and foremost thing, the glitazone is only linked to heart failure, but not to the atherosclerotic cardiovascular disease. I am talking about pioglitazone. There is a big difference between pio and rosy as far as their lipid profiles alterations are concerned. Pio is beneficial for the lipids, and it has shown enough number of trials to be protective in atherosclerotic cerebrovascular disease also. So there are good number of trials which have looked at pioglitazone and said that it is good. But slightest doubt of anything on the heart failure, edema, fluid accumulation, all those things you will get off pioglitazone. More so when you have better options of SGLT2 inhibitors and GLP-1s being available. In the same year when the rosiglitazone controversy was published, there was another meta-analysis which published in JAMA, which looked at the favorable effect of pioglitazone on all ischemic vascular complications. So this was actually, what do you call, buried down because of so much of hype behind the rosiglitazone that time. But nevertheless, if you are looking at only a atherosclerotic cardiovascular disease, pio is going to be reasonably okay, provided you are looking at the age, fluid retention and other complications into consideration. Just because you're using pioglitazone, it is not going to damage your heart. So that is the basic message. And now that you have more number of drugs which are available, possibly you can think of any of those safer options in a given patient, especially with a past history of CAD. Next patient, 42-year-old male, smoker, diabetes 3 years duration, family history of CAD. He is asymptomatic, using metformin and rosuvastatin 20, A1C of 6.1, LDL of 78. During normal annual executive checkup, everything turned out to be normal. But in view of past history or family history of CAD, not past history, family history of CAD, he wanted to be sure about the cardiac status. And one of his learned friend has said, no, ECG is not good enough. You actually should go a TMT, which will help you to determine your cardiac status. So he reported to you for TMT. So what would be the next step? Perform TMT and report accordingly. Advise angiography instead of TMT because there are a lot of false positive TMTs in diabetic. So maybe people would say, why not go for angio or perfusion scan or reassure and advise lifestyle modification. So there are two different options which have come here, A and D. This is a profile of the patient. Asymptomatic individual, normal ECG, and good glycemic control.
D seems to be the more appropriate, I think.
Pardon, sir?
As patient doesn't have any symptoms, so D seems to be the more appropriate.
Yeah, Dr. Keswani is 100% correct. If you have to screen a asymptomatic patient, only annual ECG is maximum enough. In asymptomatic patients, routine screening is not recommended because it doesn't improve outcomes as long as CVD risk factors are treated with the class well A evidence. The issue is, if you are asymptomatic, just look at controlling the glucose, controlling the blood pressure, controlling the weight, and obviously ask for smoking, ask for other things. So that is most important. So in this patient, doing TMT is actually not recommended and it is not going to lead you anywhere. So it doesn't help. So if patient has got symptoms, then also even if they are atypical symptoms also, you should be good enough. You should progress for screening. But if somebody is asymptomatic, there is no point actually looking at screening anything. So that is important to understand. Seventh patient, I think this will be the last another 5 minutes. 40-year-old male, smoker, duration of diabetes for 1 year, blood pressure of 145/85 in your clinic, currently using metformin, vildagliptin and rosuvastatin. Total
All
cholesterol of
others,
185.
all others, please mute yourself. Noise is coming.
A1C of 6.6. ABPM, which was done 1 month back, which showed a mean of 138/88 with nocturnal dipping. It was advised an antihypertensive agent by a practitioner. He is not sure whether this helps and reported to you for advice. This is the profile of the patient. 40-year-old male, smoker. BP in your clinic is 145/85. Past 138/88. So what would be the best possible option? Reassure the patient and do nothing. Recheck ABPM after a month and follow up. Advise on DASH diet and other lifestyle measures. Option C, plus antihypertensive drug. This is a profile of the patient. One response has come as B, Dr. Hemant, that is recheck ABPM after a month and follow up. What would be the ideal, say, blood pressure targets or blood pressure goals in any patient? Dr. Ajay has put D, very good. Dr. Ajay, your comments?
I think 130, anything, even if it's 145/85, if it's an office with white coat effect, still needs to be treated. And 130/80, anything above that, the threshold to start antihypertensive would be quite low for me.
100% correct, Dr. Ajay. Actually speaking, you would obviously advise anybody starting drug, you will advise the DASH diet and other lifestyle measures. Obviously, he is a smoker, so that is also important to educate. So normally 140/90 is the target. Normally, I'm talking about. But you should keep 130/80 in certain individuals with diabetes, such as younger patients with albuminuria, with additional atherosclerotic cardiovascular risk disorders. So the issue is you have young patient, male, smoker, reasonably on obese side. You should keep 130/80, 130/85, and you have a office reading high, you have a mean which is high. So you would be better off in giving them an antihypertensive agent and keep them on a lower scale. That is most important. Obviously, as far as without undue treatment burden. So, don't jump and make them into like a very low BP, but a small dose would obviously be helpful in preventing the cardiovascular risk in this patient. So these are the representative cases. I think I have taken about 20-25 minutes. The comprehensive therapy of diabetes is the most important. It is not only the glucose what matters. It is the body weight, it is the smoking, it is the antiplatelets, it is the statins. And at every visit of the patient, please educate the patient about the diet, lifestyle, all those things. Whenever all these things are educated on a regular basis, then the improvement in the outcomes is going to be visible. And whenever you have to actually make a treatment decision for the patient, look at the guidelines, look at the risk factors, look at the patient who is sitting in front of you, and actually make a decision which is the best possible for the patient. And I finish here by saying personalized care is essential for diabetes. Don't forget that it is a patient who comes for the treatment and not the diabetes by the famous diabetologist, Elliot Jocelyn Sport. I finished here. Any questions or comments, I shall be happy to take.
Thank you, Dr. Harikumar, for your nice presentation. It was really a very good talk. Instead of simple lecture, you have pointed out so many good things. These small things, if practiced properly, can definitely affect the outcome of the patients. Taking care of the statins, at what stage it is required, AC inhibitors at what stage, and to which patients are to be required, not to start in all patients. And these things, if are taken care right from beginning, then of course we can reduce the number of cardiovascular and cerebrovascular accidents.
Correct.
Thank you, Dr. Harikumar. It was a very nice talk, and it was informative and useful to all of us. And we all will like to have you again for this
Sure, sir. Sure.
presentations. It was a really good talk.
Thank you, sir. Thank you.
Thank you.
Thank you.
Thank you. So now we start for our second talk, the pulse in endocrinology, about the solitary thyroid nodule. And for this, we have one very learned speaker from Jaipur only. He is DM in endocrinology and chief endocrinologist at Santokba Dullabji Memorial Hospital. And he's a good orator and good, I can say, scientist also. So he can a academician. He's a good academician also. So I request Dr. Ajay Shah to please start your deliberation.
Thank you, Dr. Keswani, sir. You've been my teacher. First, let me just share my slides. Okay, my slides have come up?
Yes, visible and audible both.
Okay, so unlike Dr. Harikumar's presentation, which was more interactive, I have presented in a more didactic way. So I'll be talking about the newer perspective that has come up for the management of thyroid nodule. So it's my request for everyone that since I'll be presenting this as a lecture, whatever questions you may have, maybe you can just put them up in the chat box so that I can take them up. And I hope this becomes equally interactive, just like my previous speaker's talk. So this is my... So the agenda of today's talk is an approach to the thyroid nodule. And I'll be first talking something about the clinical evaluation for the thyroid nodule. And I'll be also discussing the central role of ultrasound, which has come up in evaluating the thyroid nodule. I will tell you something about the cytopathology and the Bethesda classification of cytology that is mandatory and the state of art requirement for reporting of the FNAC for thyroid. And the newer perspective includes a word about the gene expression testing. And lastly, I'll talk something about the management as an algorithm. What are the guideline recommendations? So first we begin with the epidemiology. So through the physical examination, the prevalence of thyroid nodule is slightly more.
We are not able to hear now.
As high as 75% of all general populations. That's quite high. And if you look at the autopsy series for the thyroid nodule, it approximates that which is given by the ultrasound, nearly about 60%, which is the actual prevalence of the thyroid nodule in everyone. And this translates in United States to 16 to 20 crore people harboring thyroid nodule. That's the epidemiologic burden. We keep talking about the epidemiologic burden of type 2 diabetes mellitus, but equal is the burden of thyroid nodule. And hence it becomes clinically relevant how we deal with a problem. Our own country, in Delhi, a study from Delhi reveals that 4.5% of general population, thyroid nodule 5%, which if supposing Delhi's population is taken as something like 1.5 crore, translates to nearly 7 lakh people in Delhi having thyroid nodule. That's quite high. And the reason why thyroid nodule is important is because they progress, or there is a lurking suspicion for thyroid cancer. And amongst the thyroid cancer, thyroid nodules are there in 10 to 15% of the patients. In 1975, the prevalence of thyroid cancer was less than 5 per 1 lakh population. And in the next survey, which was done in 2009, this number rose by nearly 4% to 15 per 1 lakh population, at least in United States, which means that every year there is an annual increment of 63,000 new cases of thyroid cancer being diagnosed, and which translates to the third most common cancer in the female population after breast and cervix. And one can debate that whether the cancer incidence, the number that has gone up, is an actual number, and it is debatable. Perhaps it may be, but we need to keep the fact that in 1975, ultrasound was not there. And in 2009, ultrasound was there, and hence there is an increased capture rate of the nodules, and hence the increased pickup rate for the thyroid cancer through the thyroid nodule. And you can well debate about it, but the fact remains that it is one of the common causes of cancer, particularly in females, and we should be aware about, because once in a while we will be dealing with such a case. So we can classify the thyroid nodule based on the number of thyroid nodules that are present. So it could be a solitary thyroid nodule, whereby only one thyroid nodule is found out. But if there are multiple nodules, then we call it a multinodular goiter. Based on the secretion pattern of the thyroid hormone from this, we can classify the nodule as being euthyroid nodule or a toxic. And here, the toxic does not really mean that it's an infective thing, but it refers to the excess thyroid secretion from the thyroid nodule. But some patients of hypothyroidism also present with thyroid nodule, and hence the classification. But pathologically, what we are interested is whether the thyroid nodule is a benign nodule or a malignant one. And our approach and treatment is directed in trying to differentiate the nature of the thyroid nodule. So the clinical evaluation of the thyroid nodule, it begins with history taking. And the vulnerable age group that we want to be very specific is the younger and the older age groups. That means ages less than 15 years or more than 65 years. If we find a nodule, perhaps we have to be really suspicious about the nature in this age group. And our suspicion may be heightened if there is ionizing radiation to the neck, head, or torso. And the ionizing radiation of the neck can be because of any head and neck cancer or a lymphoma or a breast cancer that the patient can have. Certain familial thyroid cancers, particularly the MEN2 types of familial thyroid cancer, the thyroid nodule can appear even in infancy or as low as about 2 years of age, at which time a prophylactic thyroid surgery could be done up. Just to say that there are certain familial thyroid cancers which will present at an earlier age, and we should be aware about this. If there is a history of rapid growth, means in few days the size increases, that's something to be looked with suspicion, because normally the thyroid nodules stay just about the same size over a period of time, so that any change in the size of the nodule with respect to time, presence or absence of hoarseness, a new onset hoarseness is an ominous sign. I mean, it's a symptom as well. So any degree of hoarseness should be viewed with great amount of suspicion in the presence of a thyroid nodule. And on a physical examination, if the consistency of the nodule is really stony hard and it is fixed either to superficial, but more commonly to the underlying structures, it is fixed, hard, stony hard nodule, you are pretty sure what you are dealing with. Presence, and this suspicion could be heightened up with presence of certain cervical lymph nodes, although they could be non-specific. Certain other conditions, benign conditions, which can lead to palpation of a cervical lymph node. But if they are there, perhaps we should be more alerted. Hoarseness in presence of vocal cord palsy is a red flag. I mean, that needs to be just looked up into and viewed with great suspicion. So once the examination is done, what are the tests that comes to our mind that we should be prescribing to such a patient? And obviously, if it's a thyroid nodule, the first test would be the TSH, because the current assays, with the current generation of the sensitive assays or ultra-sensitive assays for TSH, this becomes the first test that needs to be ordered. And if you just recapitulate 2 slides back, I had said that we need to determine the functionality of the nodule, and TSH helps in determining that functionality. The other test that could be ordered would be a thyroglobulin, although it is not routinely recommended. So these are the recommendations of the American Thyroid Associations, and they have said that thyroglobulin is perhaps not necessary in each and every case, although in patients who have undergone thyroid surgery, particularly the total thyroidectomy, doing a thyroglobulin would be mandatory on a periodic basis. And lastly, whether we should be doing for calcitonin. So here there is no recommendation. Now, no recommendation is different from not recommended. And the difference is that the cost effectiveness of doing calcitonin on each and every thyroid nodule is debated, because the assay for doing calcitonin first is not readily available. The turnover time is pretty long and it's a costly test. But if you don't do it altogether, you are never going to diagnose the medullary thyroid carcinoma, which almost always presents as a nodule. And hence, it is still debatable whether calcitonin should be done or not. And I would just say that we should use the clinical setting as a guide, whether calcitonin needs to be done or not. The next would be the imaging. And amongst the imaging, the nuclear test for thyroid, either the technetium 99, which is very readily available in most cities now, or if possible, an iodine scan. Whether it should be done in all cases of thyroid nodule? Certainly no. Only if there is a suspicion of hyperthyroidism, which means that if the TSH is abnormal or below the normal, there is a strong recommendation to do the nuclear scanning for the thyroid, because it will tell you not only the etiology, but also you could be reasonably sure that perhaps the nodule will only rarely be malignant if it is a secretory nodule, because most secretory nodules do not undergo a malignant transformation. And hence, if the TSH is low, the next test would be a nuclear scan, more commonly a technetium 99 thyroid scan, which is available everywhere, is good enough and is strongly recommended. If the TSH is normal, which will be there in most cases of thyroid nodules, or if it is high, suggesting hypothyroidism, thyroid scintigraphy is not recommended. Whether because of suspicion of malignancy, whether an FDG PET scan is required or not, for the first diagnosis, when malignancy is not under consideration, PET is not recommended, and hence the thyroid scintigraphy is the imaging if TSH is low or hyperthyroidism is on cards. But the imaging modality that needs to be done in almost every thyroid nodule is the ultrasound of the thyroid, and it is strongly recommended to do the ultrasonography of the nodules. In fact, at least in United States, where legal binding and the legal paperwork or keeping an ultrasound machine and filling up the forms is not there, most endocrinologists are doing ultrasound of the thyroid themselves rather than depend on a radiologist viewpoint. But in India, this is not the usual practice, and it's not difficult, but the logistics and the legal paperwork that is required is a very big deterrent for physicians doing the ultrasound, although some physicians are still doing the ultrasounds, and it should be done, as I had said, in all patients with thyroid nodule. So what are we looking at in the ultrasound is the size in 3 dimensions, the composition of the nodule, whether it is solid, cystic, or spongiform. And I'll take a minute. How does this look like? The echogenicity, whether it is hypoechoic or hyperechoic, the shape, particularly if it is taller than wider, that needs to be determined. The margins of the nodule, whether they are smooth or irregular, the vascularity through the power Doppler, when the probe is put up, just switch the power Doppler and determine the vascularity of the nodule. And last but not the least is the presence of microcalcification, because they are one of the most ominous signs if they are present. So I'll just take one slide because most delegates may not be very familiar with the ultrasound images of the thyroid nodule. And if you have an image like this, completely hypoechoic with very sharp margin, size less than 1 centimeter, you can be pretty much sure that it's a benign nodule and perhaps nothing. It is not malignant at all. However, if the image is little bit more, as you can see, more spongiform or more solid or partially solid to cystic, perhaps the suspicion is more than the benign one, although overall picture, the suspicion for malignancy is still low if one of these is the images. However, if it is more solid, perhaps the suspicion is raised to an intermediate level. But if you have any of these, for example, you can nicely see the stippled microcalcification with, and the second image from the left is the one with irregular margins, or if the nodule is more taller than it is wider, or there is invasion, or there is a nodule. Perhaps you are sure that the nodule you are dealing with is a malignant one. And these images you should never forget. And try to, even if we are not doing the ultrasound, it is better to discuss with the radiologist what he or she thinks about the ultrasound nature of the thyroid nodule is, because that's the purpose. So the characteristics, based on the characteristics of ultrasound alone, if the size is more than 2 centimeters, the odds ratio for it converting into nodule is more than 3. If it is solid, that odds ratio increases to 4. If there are irregular margins along with it, it further increases to 4.5. And if it is hypervascular in addition, there is further increased risk. And if it's a microcalcification that is present, very high degree of suspicion of malignancy in that nodule, which means that ultrasound, perhaps along with the clinical features, will give you a reasonable idea of what you would be dealing with. But this is not complete, and you need to add FNAC for completion of the diagnosis. And which nodules to biopsy? The old mantra, the earlier philosophy, the dominant nodule. That means one that is palpable, or the one with the biggest nodule, just biopsy that. Because thyroid nodule and thyroid cancer is one of the subjects for consumer court, either doing just too much or underdoing and missing a thyroid cancer, that has led to defensive medicine, thyroid nodule being a defense part of defensive medicine, where you just, whatever comes in your way, just biopsy up. That's not correct. But if you look at American Thyroid Association's last guidelines, we need to do the ultrasound based on the ultrasound characteristics that I have earlier described. So this is one of the ways how we perform the ultrasound guided FNA of the thyroid nodule. And you can see that the patient reclines. There is a pillow under the neck, and the probe for ultrasound is a linear probe with a frequency of 7.5 megahertz, unlike the curvilinear probe that is usually used for doing the abdominal ultrasound. That probe you can see on the machine on the top left image. So this is a linear probe that is used for performing the thyroid nodule biopsy. And as you can see, the thyroid is just on the neck. And once the patient reclines up through the image, we put the probe and we put the needle, and based on that, we take the tissue out. And as you can see, the green dot that is visible is the needle placement for doing for collecting the representative sample of the FNAC. Mind you, sometimes the patients, the nodules are solid or cystic, and you can just put in the needle and draw just the fluid. And if the needle doesn't hit the solid component, you might miss up a malignancy there. So it's important to check through the ultrasound where the needle is before subjecting into the FNAC. And based on what are the chances of ultrasound characteristics for FNA. So I just told you, if it's a benign type of lesion, less than 1% chance that it will become malignant over a period of time. Low suspicion or very low suspicion, intermediate, one I already showed you the image, but something that you should never miss is the solid hypoechoic nodule. If it is more than 1 centimeter with irregular margins, whether they are infiltrative or with microcalcifications taller than wider, perhaps the chance of malignancy is more than 75% and need to just confirm up, because that will mean an impending surgery in such cases. And these are what are the ultrasound and how is the FNAB of the thyroid nodule reported. And there is now homogeneity, and that homogeneity for a reporting of the cytopathology of thyroid nodule comes from the Bethesda classification, and there are 6 possible outcomes that are reported on the Bethesda classification. First would be non-diagnostic, which means nothing shows up on the FNA, and perhaps a blood clot or just a blood or surrounding tissue is just shown up and it is non-diagnostic. Second, it could be class 2, which means a benign, completely benign FNA. And the third is the follicular lesion of uncertain significance, or this is called as plus or AUS, uncertain significance, atypical lesion of uncertain significance. That is a gray area. Gray area even today, and I'll just take a minute about it. The fourth that could be reported would be a follicular neoplasm. Fifth would be suspicious for malignancy. And last would be clearly malignant. And clearly malignant here could be either a papillary carcinoma or follicular carcinomas are generally not so well picked up through the FNA, the Bethesda system. But if you can see it fine, MTC can very well be picked up on the FNA. And of course, anaplastic and of course, thyroid lymphoma are one of those malignancies that could be picked up on FNA. So the Bethesda classification for thyroid nodule reports in a standardized way the result as one of these 6 categories. And why they report like this is because the treatment will be based on what category you are dealing with. And just like the ultrasound characteristics, there is now good validation about the Bethesda classification. For non-diagnostic, we need to repeat it, and they are perhaps not malignant. Benign would mean less than 2% chance of the lesion being a malignant lesion. But if it is malignant, it is malignant. But what is the gray area are the categories 3, the atypia of undetermined significance or FLUS, follicular lesion of undetermined significance, follicular neoplasm. These are certain gray areas where estimated risk for malignancy is around more than 10% in various series, and which is a large number considering the epidemiologic burden of the thyroid nodule. So what could be done about it? So and I'll come back to that in just a minute or so. And I'll start with the treatment of thyroid nodule. For benign thyroid nodules, observation and reassurance for most benign lesions is the standard treatment. Earlier, there were some papers regarding suppressive therapy of thyroxine, which is currently absolutely not recommended and should not be given. But surgery could still be done on benign thyroid nodule, particularly for cosmetic reasons, or if the nodule is large enough to produce the compressive symptoms. So surgery, there could be some patients for surgery for ultrasound and FNA proven benign lesions, but they would be just a minor of them. Most would require an assurance. And I was talking about the indeterminate cytology, and that involves Bethesda classes 3, 4, and 5, the FLUS, follicular neoplasm, and suspicious for malignancy, mainly because follicular carcinoma of thyroid is not well picked up through the FNA. And therefore, help of molecular markers is resorted to should one of these classes is reported. And over a period of time, various molecular markers could be used for diagnostic methods to determine the type of nature of the thyroid nodule. And it has moved from, the molecular markers have moved from RAS, which is there for MTC, to over a period of time to a list of molecular markers apart from RAS or the BRAF or certain tags and other, but there's a whole list. What is more important is that these markers, the list has increased with time. It is further increases, but does not make up the 100% mark. That is important to see. So for category 3rd, 4th, and 5th, the FLUS or the suspicious for malignancy and follicular neoplasms, molecular testing is resorted to, and various molecular panels are used up. So 2 important that has come up in recent times are the somatic mutation testing and the mRNA gene expression platforms. And there are various other mRNA panels that are available for gene analysis. So how to measure the efficacy of these molecular tests? So one set of tests would be that test which tells us the negative predictive value, which means malignancy is ruled out. Even if the malignancy is ruled out, that is good enough information. And the other would be a positive predictive value. I would just like to remind you that these are tests. Negative predictive value means if the test is negative, it is truly benign. And if the test is truly, if it is positive, what is the chance that it is truly malignant? So based on this, one of the first tests is the mRNA gene expression classifier test. It's basically a rule out test. It's a microarray based test combining 7 distinct classifiers and interrogating expressions for 167 genes for the indeterminate nodules. And this test has 95% negative predictive value, which means that if this test is negative, with 95% surety, you can be confident that the lesion is not malignant. And the second test is the somatic mutation test, which is the rule-in test. And it comprises of BRAF, RAS, RET PTC, PAX, and other mutations, which, if they are positive, would mean high chance of malignancy, so that based on other clinical parameters, we need to choose our test. But what is the limitation? And there are other large multi-gene panels of mutation markers, but I would just like to summarize the results of the molecular testing. overall, in general, these molecular testings are quite specific, more than 85% specific, and therefore positive predictive value is more than 85%. But the flip side is that they are only sensitive in about 45% of patients, or even less, quite low sensitivity, which means you are going to miss out certain cases, and which completely defeats the purpose why you are using the molecular test in the first place if it misses out. Low sensitivity, the method is the RT-PCR method. Although the machine is available, the probes are available only with great difficulty, so that at least even in United States, the cost of this test is exorbitant, not available in India. Most thyroidologists have not used it. So coming back to the treatment part, I discussed about the treatment of benign nodules, and coming to the indeterminate nodules. So for flush lesions, you can either do a surveillance, which is done in most cases. But if the patient is quite fussy and has a paranoid type of personality, better to do a diagnostic surgery. This is a diagnostic surgery, mind you. But if the report is follicular neoplasm or suspicious of malignancy, it is not good to just observe the patients, but rather perform the diagnostic surgery. If it is malignant lesion, obviously there's no debate altogether, and you just need to perform the surgery. The extent of surgery will be debatable, but surgery needs to be performed based on so many other factors. So the American Thyroid Association's algorithm for management of thyroid nodule is that if you have a thyroid nodule, the first thing to do is to do a TSH and know whether it is elevated, normal, or below normal. And once it is found out that it is normal or elevated, we need to perform the sonography or the ultrasound of the neck. And based on the characteristics of the ultrasound, we can classify whether it's a benign, has a very low or low suspicion of ultrasound pattern of for malignancy, or an intermediate suspicion, or a high suspicion. So for categories that are very low, low, and intermediate, we need to perform FNA if the size of the nodule is more than at least 2 centimeters, or for intermediate lesions, at least 1.5 centimeters. Otherwise, we can simply observe up. For high suspicion, doing an FNA, the size needs to be 1 centimeter or greater. And based on the cytology results reported on the Bethesda system, we can either classify the patients as non-diagnostic, which means we need to repeat an FNA, perhaps an ultrasound guided. If it is benign, just observe the patient. But if there is an intermediate type of lesion, even on the FNA of the lesion, perhaps resort to the molecular markers, and that would mean, and here is the role of precision medicine, these group of patients, what to do, need to discuss with the patients, look at the resources and the risk profile of the patients as the next step. But if the patient has malignancy, need to do the surgery anyhow. So dear friends, that would be the approach of thyroid nodules. And I have told you some of the newer perspective, particularly the gene markers. I've already told you the performance of the thyroid nodule through ultrasound. Either you can do it yourself or you can take help of an interventional radiologist. But what you should be looking for, you should be pretty much clear enough. So that now, if you have any questions regarding my presentation, I'll be happy to take.
Thank you, Dr. Ajay. It was a very nice presentation. And initially, I had some questions: which patient we should go for the FNAC, and in later slides you have already explained them. And one thing, do you have any experience of giving suppressive therapy to the patients of benign nodules or colloid nodules? Have you ever tried?
No, I have not tried, because um, that was tried up even before I did my DM. So that school of thought is completely obliterated in current times. So doesn't really shrink the thyroid nodules.
But the problem with me is that I am using that therapy for a very long, since we were students. And what I think, what I see is many of the patients with benign nodules, the nodules have been disappeared. Even the
So,
colloid nodules, that of course colloid nodules take much longer time. And how ethical and how good is it? But many of the patients have disappearance of nodules. If we confirm that they are caught,
maybe you can try to correlate if these patients are frankly or subclinically hypothyroid. These nodules will shrink anyway. So maybe you can do a correlation like that, but
or
most guidelines
maybe of that kind, that they may have been disappeared without treatment also.
without treatment also. Yeah, that was my, yeah.
So what I am giving, when the patient says that if I am not going to for surgery and you ask, give me any treatment, I prescribe for 25 microgram of thyroxine, and I advise them to come after 3 months. So they say, "Ha, sab, thodi si naram pad gayi." And then in subsequent visits, they say that, yes, this.
I think there has to be an there has to be an element of objectivity. Thodi si naram pad gayi is too subjective. So it's more wishful thinking than anything else. So that needs to be there. I think I saw one question in the chat box, which reads that in asymptomatic patient except swelling, once FNA ultrasound guided showed no malignancy, how frequently would you recommend repeat what, an ultrasound or FNA? So maybe a periodic surveillance based on the individual characteristics. But I would suggest that doing an ultrasound annually is what is recommended. And if there is a change in size or change in ultrasound characteristic, go in for an FNA in such a case. So an observation would be more prudent. A change is important, which means that you should have a baseline, and after a period of time, if change has occurred, then do at a site where change has occurred.
Thank you, Dr. Ajay, for a nice presentation. Cleared many of the confusions about the managing solitary thyroid nodules, and for how we should proceed and what investigations have to be done. Do not give thyroxine to otherwise benign nodules, what many of us maybe have been giving, like me. And thank you, Dr. Ajay, for your nice presentation and being with us, for giving this lecture to our audience. And next time again, we will bother you for some.
Thank you, and I'll wait.
Bye-bye. Thank you.
Thank you.
Thank you, sir. Dr. K V S Harikumar must have left, I think. Yes.